morning, everyone, and welcome to today's webinar on the Department's efforts to share psychotropic medication data. I want to quickly remind everyone that the phones are currently on mute. If you are unable to hear us, please let us know by using the chat function in the webinar. We will have a question and answer session at the end of the presentation where we will answer questions submitted via the chat. Let's get started with some introductions of today's presenters. My name is Lori Fuller. I'm the Chief of the Permanency Policy Bureau here at the Department of Social Services.
Hi, my name is Alicia Sandoval. I'm the Chief of the Child Welfare Data Analysis Bureau here at CDSS.
Good morning. My name is Jennifer White. I'm a researcher here at the Child Welfare Data Analysis Bureau here at CDSS.
Before we get started with the presentation, just want to cover some housekeeping items. As I mentioned before, your phones are muted, and there will be a question and answer session at the end of the presentation. Due to the large volume of folks we have registered for the webinar today, we will not be taking live questions. However, you can type your questions into the chat box at any time, and we will provide responses at the end. You can also send us emails or feedback. Data-related emails can be sent to cwsdata@dss.ca.gov, and policy-related emails can be sent to qipsychotropic@dss.ca.gov. Today's webinar will also be recorded and posted for viewing at a later date. Today's webinar will focus on providing counties with guidance and information on recent data sharing activities related to psychotropic medication. We will be providing information on the purpose of this webinar, some background of these data sharing efforts, the new psychotropic medications data sharing agreement, the existing global data sharing agreement, and we will be reviewing the implementation activities for Senate Bill 238 and 484. The primary purpose of today's webinar is to provide information on the tools available that will allow counties to more effectively monitor the use of psychotropic medication among children in foster care. There were several events that preceded the development of the psychotropic medication data sharing practices in California. In 2008, California participated in a 16-state study conducted by the State Medicaid Medi-Cal Directors Learning Network and the Rutgers Center for Education and Research on Mental Health Therapeutics. The study was conducted to identify possible safety and quality issues surrounding antipsychotic drug use in children and youth. The results indicated that California foster children were 5 times more likely to receive psychotropic drugs compared to non-foster care children. And of those children, more than half were prescribed 2 or more psychotropic medications at the same time. Then in 2012, the Child and Family Services Improvement Act was passed, and states were required to specify protocols for appropriate use and monitoring of psychotropic medication for children in foster care in their state plans. Also in 2012, the Department of Social Services and the Department of Healthcare Services teamed up to form the QI project. The primary purpose of this project is to explore, identify, and support effective strategies for overseeing and monitoring the use of psychotropic medications for children and youth in the foster care system. Shortly after the project began, the departments identified a need to share data from their respective systems and began to develop various data sharing agreements. A few other events further defined ways in which data would be shared between CDSS and CHCS, and also methods for sharing this same data with counties. Beginning in 2015, the California State Auditor examined the oversight and monitoring practices of CDSS, DHCS, and 4 California counties. In the auditor's report published in August 2016, the collection and sharing of data was identified as a much-needed resource to improve practice at both the state and county level. These preceding activities culminated in the passing of a package of legislation in 2015 and 2016 to improve the oversight and monitoring of psychotropic medications for children in care. As a result of the new legislation and the lessons learned from the QI project, CDSS, in partnership with DHCS and many other stakeholders, are conducting several activities to implement the new legislative requirements and to continue efforts to improve the safe use of psychotropic medication for youth in foster care. Beginning in the fall of 2016, the Psychotropic Medication Implementation Work Group consisting of stakeholders and counties, began to work on necessary activities to enact the state legislation. The next work group meeting for this group is scheduled for this coming Thursday, January 12th, from 1 to 3 here in the CDSS building. Through the work group, CDSS developed a methodology to identify group homes warranting additional review based on their psychotropic medication use and provided feedback regarding the process and procedures for the licensing program analysts who would be doing the inspections. The Community Care Licensing Division began inspections in late 2016. To date, well over 100 facilities have been inspected, and those providers have been advised as to improvements that should be made in their facilities. CDSS has also begun to analyze data from the CDSS psychotropic measures and has begun conducting case reviews and working with counties to obtain additional information regarding children with concerning concurrency rates or medication use at very young ages. Another aspect of the project that is still going on is educational materials regarding health and wellness topics have been developed, and some of these will soon be available on the CDSS website. Another aspect of SB 238 that this group has been working with the CalSWEC folks on is to develop classroom training curriculum for social workers, probation officers, and public health nurses. The group provided input, and the curriculum is now in a pilot phase and will be tested over the next few months and available for attendance in the spring session. Also, an e-learning training on psychotropic medication is nearly complete and is being piloted by various parties at this time. This particular training will be valuable for all parties who work with foster youth, such as caregivers, CASAs, attorneys, educators, parents, and others. In support of these activities, CDSS and DHCS entered into several data sharing agreements that allowed for the exchange of confidential health information between CWS, CMS, and Medi-Cal paid claims. I'm now going to turn it over to Alicia Sandoval, who will be sharing more information on these agreements.
Thanks, Lori. Good morning, everyone. As Lori mentioned, there are several data sharing agreements that currently exist to support oversight and monitoring of psychotropic medication use for children in foster care. These agreements, which we'll discuss in more detail, allow the department to match data between children in the Child Welfare Services system and the state's Medi-Cal system. This match data allows us to identify children with a paid Medi-Cal claim for a specific service, and CDSS may share these data with counties for the children under their care and supervision by becoming signatory to one of the two agreements. So the two agreements are the Global Data Sharing Agreement, and the other agreement is our new Psychotropic Medication Data Sharing Agreement. I do want to point out that counties should only opt into one of these two agreements. So by signing onto one of the agreements, the two state departments and counties agree to exchange confidential and non-confidential data. Currently, we have 24 counties that are receiving data elements that are shown on the screen via one of the two agreements. The data includes demographic and client information, case and placement data, medication details, and some pharmacy and prescriber information. So many of you know and are familiar with the Global Data Sharing Agreement, which was executed on April 9th, 2015 between CDSS and DHCS. We issued an ACIN, which was sent to this effect on May 12th, 2015 to all counties. So the global part of this agreement refers to an open exchange of individual client-level data between CDSS, DHCS, and counties that opt into the agreement for all medication and health information for youth receiving child welfare services. The data available through the agreement includes Medi-Cal eligibility and demographic information, and Medi-Cal paid claims for, and there's a list of the data. As you can see, it's pretty broad. We have eligibility, demographic, medical, mental health, payment, and medication data. Data received through the agreement can be used for allowable purposes that are indicated in the MOU for children, non-minor dependents who are receiving child welfare services. So the second agreement is a new agreement, and it's available for counties. It's our newly executed psychotropic medication data sharing agreement. And this was executed last month on December 2nd between the two state departments, CDSS and DHCS. ACIN I-87-17 was issued last month and provides more information on this agreement. So the data available through this agreement is limited to data pertaining to psychotropic medications. And it's important to note that the data received through this agreement may only be used for the health oversight activities for children in out-of-home care. I also wanted to note that the agreement does not require entering as a DHCS business associate, which is a requirement for the global agreement. Okay, so the process. It's fairly simple and only requires a few steps. First, we ask that your director or appropriate authority sign the signatory page of one of the agreements and email it to us to begin the process. The email is listed there on the screen, cwsdata@dss.ca.gov. After we receive the signatory page, we ask that you complete a data request form to begin the data transmission process. We have a completed sample data request form to assist counties, and we also have a secure file transfer process. We do need counties to submit this secure file transfer access form, which will allow us to send you the data easily and securely through our SFT. For counties under the global agreement, we ask that you submit an authorized requester form as well. So again, we have the email listed above. And please, if you have any questions at all about the process, email us and we'll be happy to respond. Okay, so that's it with the data sharing agreements. And Jennifer White will now talk about how the department has been using the matched data we've received through these agreements to improve the oversight and monitoring of psychotropic medication use.
Good morning, everyone. As Alicia mentioned, the execution of these agreements between the two state departments has allowed us to develop some tools to enhance the oversight and monitoring of psychotropic medication use for children in foster care. These tools include the 7 child welfare psychotropic medication measures, the quarterly JV 220 reconciliation reports between court consent dates in CWS CMS and psychotropic medication paid claims data through Medi-Cal, data indicators identified in Senate Bill 238, and then similarly SB 238 requires monthly data reports. So many of you, I hope, are familiar with the 7 child welfare psychotropic medication measures that were developed in early 2015 through stakeholder input. The first 2 measures, use of psychotropic and antipsychotic medications, Measure 5A1 and 5A2, which I'll be going over in more detail, is our baseline measure and provides accounts of use identified through paid claims data on psychotropic and antipsychotic medications. The second measure was developed because of risks associated with taking multiple medications at the same time. Use of multiple concurrent medications, Measure 5C, was developed to identify use on multiple concurrent medications for 60 days, with identifiers for youth who are on 2 or more psychotropic medications at the same time, 2 or more antipsychotic medications at the same time, at least 1 antipsychotic at the same time as a psychotropic. Because antipsychotic medications have serious, common side effects including weight gain, diabetes, and metabolic disturbance, ongoing metabolic monitoring for use on antipsychotic medication, Measure 5D, was developed for those with ongoing antipsychotic use and addresses the need for continued monitoring of medication side effects. This measure identifies youth on 2 antipsychotic medications on different dates of service and who had both a test for cholesterol and a test for blood glucose. The fourth measure, use of first-line psychosocial care, Measure 5E, encourages use of psychosocial intervention as a first-line treatment for children. This measure identifies youth who had a documentation for psychosocial care 3 months before or a month after the new psychotropic prescription. The next 2 measures look at services for youth who begin treatment. Follow-up visits for youth on psychotropic medication, Measure 5G, looks at youth who had a follow-up visit with a doctor within a month of the new medication. And metabolic screening for youth newly on antipsychotic medication, Measure 5H, creates a baseline before side effects begin. And this measure looks at youth who had a lab test for sugar or cholesterol 3 months before or 15 days after the start of the new medication. We know this is a lot of information to digest. The slides and the recording of this webinar will be made available for viewing, as Lori mentioned earlier. We also have a document of these measures for those interested, and ACIN I-3615 also has some references to these measures. So the first measure, use of antipsychotic and psychotropic medications, Measure 5A1 and 5A2, was first released to the public on October 6, 2015 on the UC Berkeley website, which I hope you all are familiar with, and it has been updated quarterly since then. And this uses matched data between Medi-Cal and CBS CMS and displays the number of children with a Medi-Cal paid claim for psychotropic medication, the number of children in foster care in the period, and then those children who were in foster care while they received the paid claim. Counties that are signatory to one of the 2 agreements that Alicia presented are provided with client-level medication-specific claims data of those elements that she listed in previous slides. The specific information on this measure, the methodology, are on the Berkeley website, including the list of medications that are considered psychotropic. The third measure, the third of 7 measures, is the use of multiple concurrent psychotropic medications, Measure 5C. And this measure will display the number of children in foster care with a paid claim for 2 or more medications for 60 days, the number of children in foster care on at least 1 medication for 60 days, and then we provide a percentage. An email was distributed earlier last informing counties that test data for this measure was posted on the Child Welfare Extranet. After a 1-month county review period, we anticipate posting these data publicly on the Berkeley website in a similar fashion we did for Measure 5A. If counties, those emails were sent to county welfare directors and chief probation officers. If you need assistance accessing the Child Welfare Extranet or would like the password that was issued to your county, please feel free to send us an email and we'll get that to you as soon as we can. Another tool counties can use for monitoring oversight include the JV 220 reconciliation reports, which are reconciliations against the JV 220 court authorizations against the DHCS Medi-Cal paid claims data. Since May 2015, counties have been receiving quarterly reports of confidential data that identifies youth through case IDs who received a paid claim for psychotropic medication but did not have a prior court order consent entered in CBS CMS. The reports simply identify whether a youth has a paid claim without a prior court order consent entered in CBS CMS. We want to note that legally the JV 220s are considered valid for 6 months from the authorization date and must be renewed every 6 months thereafter. However, for the purposes of this report, they are considered valid for 12 months following the court authorization date. This 12-month time frame was agreed upon by stakeholders and county partners to allow for things such as court continuances and other case delays. For these reports, court consent dates are considered valid if they are dated on or before the Medi-Cal paid claim by 12 months. We would like to acknowledge that there are some limitations to this report. For example, there may be some instances where the authorizations are dated after the paid claim date, which have perfectly good explanations, such as emergency situations or children who come into care with an existing medication. These reports may also include parental consent, appropriately, expired consents, or consents that are not updated or entered in CBS CMS. We are also unable to reconcile the medication-specific authorizations, meaning we can really only compare dates between the two systems, Medi-Cal and CWS CMS. We also want to recognize that there may be alternative documentation of a valid court authorization either in a hard copy file or an external data system. However, given that CWS CMS is the official statewide child welfare case management system, this data is what is available to the state to share with counties. So I'm going to go through an example. And I'm going through this because we received many questions on the JV 220 reconciliation reports. So in this example of a report that counties are currently receiving, the report has one child listed with that following case ID. Counties receive a file with case IDs that identify youth who received at least one paid claim with no preceding authorization. As a county, your first step would be to go into CWS CMS and look at that record for that youth. For youth on one medication, this reconciliation is fairly simple. You may find that there is, in fact, no authorization documented or in the file, which would then warrant further discussion with your youth care provider. However, you may see, as in this instance, Susie has a court order documented, and you would wonder why she's included in the report. And so we want to explain why. CDSS receives information from DHCS that in this example, the paid claim was received prior to the court authorization date, and that's why Susie's included. Other instances would be where you have an authorization that is dated more than a year prior to the paid claim. Or simply there's no authorization entered, as I said previously, or updated, and you want to talk to care providers. Or you see that the authorization on file is either old or dated after the paid claim. So that was a fairly easy example. The second example is a little more complicated, where a youth has more than one authorization in CWS CMS. As described before, counties receive a file with case IDs that indicate youth who receive at least one paid claim with no preceding authorization. In this instance, when you look at Johnny's case, he does in fact have an authorization, and actually he has two of them. But what CDSS can see via shared data with DHCS is that Johnny received two medications. In this case, he received an antipsychotic and a psychotropic. The March prescription is valid because the authorization is dated before the paid claim. You can see that here. However, January is not, because this authorization is over a year old, and that's why Johnny's included in this report. Now, CDSS recognizes that without medication-specific reconciliations, especially with youth on more than one medication, this information is challenging to reconcile with your county records. The hope is that these reports can be a tool for case management and provide you all with a flag that something should be investigated for this case as it pertains to psychotropic medication. However, again, counties can receive individual client-level medication-specific information by signing on to one of the two agreements. Counties that enter into one of the two agreements will be able to receive data containing confidential information pertaining to the children under their county's care and supervision. Okay, on to SB 238 reporting requirements. In 2015, Senate Bill 238 was passed, which required the department to provide counties that are signatory to one of the agreements with monthly data reports that include specified information regarding each child for whom one or more psychotropic medications have been paid for under Medi-Cal. To facilitate this monthly reporting, CDSS is currently engaging the Children's Research Center to be able to use the Safe Measures platform for more efficient access to these reports. By next month, we expect signatory counties to be able to access these reports in the Safe Measures Data Analytics and Case Management platform by viewing their existing 5A1 and 5A2 reports. In addition to the monthly reporting requirements, SB 238 also specifies two data indicators, one for identifying children under 5 and under on at least one psychotropic medication, and another identifying a child of any age on 3 or more concurrent medications. Through the stakeholder process, we are also developing 4 additional indicators that include an indicator for polypharmacy by each of the medication drug classes. Additional indicators are that medications that exceed the recommended dosages, off-label use, and identifying the length of time a child has been on a medication by each of the drug classes. Again, we know that this is a lot of information in a short presentation. However, we hope it gave counties information on how the exchange of matched data can enhance your current efforts to provide oversight and monitoring for psychotropic medication use for children in our care. On this slide are a few resources as references. Again, the slides and the recording will be made available for viewing at a later date. Now we will begin going through the questions. I hope you have a lot of them and that you've entered them into the chat box, and we'll go through them in the order.
Great. Hi, this is Alicia, and I just wanted to follow back, if we can go back to the resources slide. Yeah, that slide's fine as well. I just wanted to note that we did make an error on this slide. The ACIN number is I-8716, not 17. I just want to make sure that everyone is looking up the right ACIN if you want information on the psychotropic medication data sharing agreement. But it is correctly identified in that other slide, which is the one right before this, right there. So that is the correct I-8716. Thanks, Jen.
Hi, this is Nathan Morris with the Child Welfare Data Analysis Bureau at CDSS, and I'm just going to be reading off the questions from the webinar. So our first question is here, is what is the address for the health and wellness website? And if it doesn't exist yet, when do you expect to launch it? And I'm told that in February 2016 is when this, February 2017, right, is when this website will launch, and we will make we'll make the web address for that. We'll give you a link to all those who participate in this webinar. The next question is, for the psychotropic medication data sharing agreement, precisely what information will be shared with counties, in parentheses, child welfare agencies, from DHCS? The ACIN refers generally to client-level psychotropic medication information being available.
So we did list in one of the slides the different types of data that we would be able to share. So it does pertain to medication data. It would be slide, you can reference it again. If you can go back to slide number 13. So I think what we really want to make sure that counties are clear on is that the data that you receive through this agreement is specifically for the health and oversight activities for kids, but we will be sharing all psychotropic medication data, which we also have listed. I guess we don't have. Slide 11. No, I don't think we have it in detail either. So we have medication names. We have
so it's on slide 9.
Oh, thank you. There we go.
So currently, counties who are signatory to one of the two agreements are receiving these data, and that's the demographic data and client-level information. That's the client-level demographic data is from CWS CMS. Obviously, the case information, placement name, address, dates, foster care episode, case dates, all that good stuff, that's from CWS CMS. The medication details, the name of the medication, the dates of those medications, the strength units, the supplies, drug codes, those are from Medi-Cal, the Medi-Cal system. And then we have the prescriber name, address, specialty, prescriber's national provider index number, that's from Medi-Cal, as well as the pharmacy name and address and the pharmacy ID, those are from Medi-Cal. And that's what's currently being exchanged.
Thank you. The next question is, are you going to send this PowerPoint to participants? And as we discussed, this presentation, recorded presentation, will be uploaded to the CDSS YouTube
Will be providing a link to this presentation, the recorded, and then we'll be distributing the slides as well, a PDF of the slides.
So everybody who registered for the webinar will receive an email that gives all of these links.
The next question says, in what manner will the information be transferred to counties and how often? For example, are there any system requirements for counties?
So we're currently transferring Excel files via secure file transfer account. So I went over the different forms that counties need to provide. As soon as we receive your secure file transfer request, we will issue an account, and that's how the data transfers are conducted. And again, you'll receive an Excel file.
All right, the next question is, please restate the authority for the 7 psychotropic measures.
The authority?
Authority.
So SB 484 lists HEDIS measures as well as child welfare psychotropic medication measures. I don't have this specific authority on me, but it's SB 484.
In the Welfare and Institutions Code. I don't remember the precise, but we can also reference that when we send our next email to the group.
Sure.
All right, the next question is, do counties need to have a named point of contact for receiving the information? For example, agency director or designee, child welfare director, IT director, etc. I assume this is talking about the psychotropic medication data.
So for both of the agreements, we indicated that your child welfare director or other designee should sign the actual agreement. But then we do need some county point of contact to work with. With the Global Data Sharing Agreement, we have an authorized requester form that we ask directors or whoever signs the agreement to complete so that we have a contact person. With the new psychotropic medications agreement, the signatory page actually includes a section for our contacts.
Okay, the next question is, are the agreements only with CFS foster youth? How are youth in foster care under 602 placement orders, in parentheses, foster care youth under probation impacted?
So we are exchanging probation data as well. Probation youth are included in our population.
Next question, are the agreements, other than submitting a signed agreement, completed data request form and secure file transfer access form, is there any information counties will be required to provide to DHCS in exchange for this information?
No, there is no requirement for counties to provide DHCS with any info. The counties work directly with CDSS.
There is discussion about the availability of therapy and other medical services received in addition to medicine, but that does not seem to be shared under the Global Data Sharing Agreement yet. Is that correct? When will it be available? Thanks.
Well, the authority is under the Global Data Sharing Agreement, but we have not begun to transmit that type of data yet, but we do plan to do so in the future. Mental health services is a category.
Where is the actual diagnosis of the child listed, and how is that information used for the Safe Measures site?
So the Safe Measures site currently has diagnosis entered. Safe Measures is currently only has access to CWS CMS data currently, and it uses, I believe, the client condition table or something like that in the health and education notebook in CWS CMS. It does not currently use any external data system outside CWS CMS for the purpose of psychotropic medication. By next month, signatory counties will be able to access medication data. We don't have any diagnosis data from Medi-Cal yet.
The next question is, how will Safe Measures pull data differentiating between which medications are antipsychotics?
we will be providing, through the agreement, Safe Measures, or the Children's Research Center is a contractor under through the agreement, and so we will be sending them an indicator for which medications are antipsychotic, and that indicator for antipsychotic is provided to us by our partners at Healthcare Services.
Please repeat how to access 5C multiple concurrent data report.
The multiple concurrent psychotropic medications measure 5C report test data is on the Child Welfare Extranet site. An email was sent to child welfare directors and chief probation officers, I think Tuesday last week, January 3rd.
And if you need that email resent, should they write into the mailbox and request that?
Yes, please write into the mailbox. There's instructions on the email that you should use your county's previously issued password to access the Child Welfare Extranet. And if you need assistance with recovering your password, please send an email to the cwsdata@dss.ca.gov email box.
All right, that's all the questions I see.
We'll pause here just for a moment, and if anybody else has another question or two, please type it in now.
Hi, this is Nathan again. We have a couple more questions that were added. The next question is, please state the data that will be shared in option 2.
So option 2, I'm assuming they are referring to the psychotropic medication agreement, which is the second agreement. I think we already went over the data elements that were on slide 9. Can you go back to slide 9?
Okay, the next question is, will mental health data be available in the regular data sharing agreement?
Regular data sharing agreement, I'm going to interpret that as the global data sharing agreement. So mental health services data will be available via the global data sharing agreement. Counties do have to request the data using the data request form that we supply.
We are also meeting regularly with signatory counties on the various data requests and data needs. So through those meetings, we have a list that includes mental health data as counties have requested and have asked for the need.
So for counties who have not yet signed on to one of the agreements, as soon as they do so, they'll be added to these calls.
Yes.
And they can talk about additional data needs during those calls. And
right.
we will be able to supply additional data elements if they are available.
Right, right.
We, of course, have to work with our partners at DHCS about access and availability of those data.
Right.
I have a question here. It says, I suppose I'm meaning counties. Do counties need to provide data, or does a county have to match data?
So counties do not provide data. Data that is used to match in Medi-Cal is data entered into CWS CMS. We use the client information, name, date of birth, social security number, that match. Those data elements are then used to match against same data elements in the Medi-Cal system, and the match is done statewide and then provided to counties that way.
Please please confirm that only county child welfare can enter into these agreements versus county behavioral health.
So I'll first touch base with the global data sharing agreement. With the global agreement, behavioral health departments can sign on to the agreement. We do have one county currently where we have a behavioral health department that has signed on. I'll assume that the reference was to the global agreement.
Well, it says these agreements, whether they can enter into these agreements. So plural, I'm assuming, would be either or. I think we're checking on that. The previous question about will mental health data be available in a regular data sharing agreement, it says they're referring to the regular, the non-global agreement.
So currently what's being exchanged is the data that's available on slide 9 here. As future data becomes available, we can work with our partners at DHCS to determine whether or not it can also be shared under the psychotropic medications data sharing agreement.
The next question is, where will the data differentiate between children in group homes and children in FFA or relative rest from home? Are we also keeping track of children taking psychotropic medication in a home of parents?
Regarding the question around placement type, differentiating between group homes and FFAs, we do. Measure 5A currently has a table that breaks it down by supervising agency by placement type. So all the pertinent placement types that we're all familiar with, group homes, FFAs, FFHs, dependent guardian homes, those are all included and identified in the data that counties are receiving. The methodology for 5A is looking at the most recent paid claim in which a youth was in out-of-home care. Where were they on that paid claim date, either group home or the various placement types? And then the second part of that question, can you repeat that again, Nathan?
The second part is, are we also keeping track of children taking psychotropic medication in a home of parents?
No, we are not. So the psychotropic medications data is only looking for children in out-of-home care.
The next question is, if we have signed the global data sharing agreement, do we get the mental health services on the paid claims report, or do we have to request it separately?
You do have to request the mental health services data, again, using our data request form. But yes, if you've opted into the global, you can have access to that data.
Okay, the next question is, will the file include all children, or only children that match the demographics of county-specific clients?
Only matched data are included. So if there was a positive match between the CWS CMS client identifiers and the Medi-Cal client identifiers, then that data is included, and that those children met the conditions specified in the specifications for the measures.
Next question is, what data is provided in the global agreement but not in option 2?
So in the global agreement, if we go back to slide 11, with the global data sharing agreement, it offers a much broader range of data. It includes eligibility, payment information, medical information. With the psychotropic medication agreement, the newer agreement, we are limited to data that pertains to psychotropic medication.
The next question is there a list of which counties have signed off on each of the 2 agreements?
Yes, we do have a list of the counties, and we can share that when we respond to everyone.
All right, that's all the questions for now.
Okay, I think we had one that is still unanswered. It had to do with whether behavioral health departments can sign on to the psychotropic medications agreement.
Yes, it said, please confirm that only county child welfare can enter into these agreements versus county behavioral health.
So I think we said that the behavioral health departments have signed on to, at least one has signed on to the global data sharing agreement. The way the MOU for the psychotropic medications data agreement, it is broadly allowing counties to sign on. We'll need to probably consult with our counterparts at DHCS to determine whether or not it would be appropriate for behavioral health to sign on to the psychotropic medications MOU as well.
All right, the next question is, what data is included in the mental health services under the global sharing agreement?
Hi, we still need to work with our partners at DHCS to identify the specific data elements that we would share. And as Jennifer had mentioned earlier, the regular meetings that we have with counties that have opted into the global, it's a great forum to discuss what would be helpful for counties. So if you do opt in or if you have opted in, please be sure to participate so that we can have a really good informed discussion so that we can move forward with whichever mental health services data elements would be most helpful.
Next question is, we were wondering why you are trying to develop data indicators for the monthly report when the state already adopted guidelines for using psychotropic medications. Wouldn't you want to just create the data indicators from those guidelines?
Many of the guidelines are from many of the indicators are from the guidelines. The first two indicators that I mentioned, children under 5 and 3 or more concurrent psychotropic medications, those are specified in SB 238, informed by the guidelines, obviously, and then the others are similarly also from the guidelines. The intent of the indicators is to simply provide counties with an easy-to-access flag for them to identify which children met those criteria, so that you wouldn't have to comb through all, hundreds of records to be able to figure out what these are. It's basically just an easy way to identify those children.
All right, that's all the questions we have for now.
All right. Again, we thank you all for participating in today's webinar. We have currently on the screen, again, the mailbox addresses that you can write in if you have additional questions, if you want any other information. Another great way to participate and get more information about these topics is to join our implementation work group, which you can email interest, and we will get you on that mailing list if you email the QI Psychotropic address up there. And again, our next meeting is this Thursday from 1 p.m. to 3 p.m. here at CDSS. If you're interested, email the mailbox and we'll send you those materials. Thank you again.